I'd like to thank everyone on behalf of Nestle for coming today for what looks to be a very exciting and a novel way of actually delivering teaching and education about cow's milk protein allergy. I'm very excited to see how this afternoon pans out. I was a general paediatrician for a while, but I guess in the last 10 years I've moved into children's allergy, and this probably sort of sprung from my own daughter, who's 15, who still remains incredibly allergic to a lot of different foods, which has sort of spurred my interest in allergy initially. So I guess I see allergy from both sides, both as a clinician, but also, knowing what it's like as a parent, taking my daughter out to restaurants, those phone calls that I get at 8 o'clock saying she's in a restaurant, she doesn't know what to eat. So some of the practical issues certainly are very, very true to me. I'm informed that we've got a big team of dietitians in the audience who are very experienced, almost certainly, in the management of cow's milk protein allergy. And I'm hoping that I'm not going to be telling you too much in the next sort of half hour that you don't already know, because it's just sort of reinforcing different types of milk and how we sort of diagnose cow's milk protein allergy. I'm an allergist in Leeds now, and we, like all areas in the country, have an absolute epidemic of allergy across the board. For a while I was single-handed, but thankfully the Trust have put their hand in their pocket and have supplied me with a consultant colleague, and the two of us work very closely. But we still see an excess of sort of 50 to 60, 70 new patients a month that are referred through to us. Ironically, most of the children with cow's milk protein allergy aren't looked after by our service, they're managed in the community. But so we do have sort of close links, but we do have about 12 or 1,400 new cow's milk protein allergy patients a year in Leeds. And I'm sure if you were to get local numbers from where you all work, the numbers will be very similar. So this is a huge problem, and still, to my mind, underdiagnosed when people don't actually think of the diagnosis. So in terms of a bit of sort of immunology background, we know that allergy is an adverse immune reaction to a molecule, which is usually a protein, in the environment, which to the most of us is harmless. And then this is quite an important sort of slide in terms of how we sort of categorise children and adults who have adverse reactions to food. There are those people who clearly are not allergic, and those include sort of intolerances such as lactose intolerance. There are those people that have had a sort of reaction to either drugs or due to sort of bacteria present in food. There are quite a lot of people who have psychological issues and an aversion to food, and we see more and more of these where actually the families are the main problem rather than the children themselves. In terms of those children that are allergic, there are two big cohorts. There are those that clearly have IgE-mediated allergy, and we'll talk a bit more about that in a second. But certainly for today, when we're talking about cow's milk protein intolerance, or as we like to call it now, the non-IgE-mediated milk allergy, which is much more difficult to diagnose because there isn't any testing. So the IgE-mediated allergy we all understand, and it's very straightforward. It's an immune reaction driven by mast cells who then release histamine. So the response is very easy to understand because we know what histamine does when it's released, but the classic symptoms of urticaria, rash, angioedema, and anaphylaxis. And it's a nice, clean type of allergy because we have testing that supports the clinical history. So you get a classical history of allergy, you can then either do skin testing or blood testing, and it all usually fits together nice and neatly. The non-IgE mediated allergy, we don't really understand quite as much, but it's probably not an immune reaction, but is driven by eosinophils and T cells. The symptoms are delayed, and they can be delayed hours to days, and often are dose related. So again, we talk about thresholds of some foods that children will tolerate, but most of them do have a threshold. The more food they have, the more symptomatic they are. The typical symptoms affect the GI tract and the skin. And as I said previously, there is no allergy testing that you can do that supports the diagnosis because it's not histamine based, there's no mast cells, so you can't order blood tests, there's nothing that skin test will tell you. And you can do biopsies and look for increased presence of eosinophils and T cells in the esophagus and the gut, but that is not the procedure that we subject children to. And the diagnostic test is to remove the offending protein from the diet and look for a symptomatic improvement in symptoms. Cow's milk protein allergy is phenomenally common, and we know that up to 15% of children at some point will have some sort of symptoms suggestive of cow's milk protein allergy. The true prevalence is somewhere around about sort of 5%. And it is important to try and make an accurate diagnosis. And those are the numbers for the UK in terms of new patients per year, and certainly that's our experience, in Leeds with 12, 15 new patients diagnosed per year, which is clearly a huge burden of work in terms of dietetic support and in terms of clinic support for these children. Cow's milk protein intolerance is an immunological reaction to one or more milk proteins. So we recognise there's about 25 different proteins present in cow's milk that can induce a cow's milk allergy, and it's very different, as you know, and distinct from lactose intolerance. And this is a slide that I commonly use in my talks, but you can see that we're no different in the UK from North America, and very similar to sort of Australia, Israel, other parts of the world where milk allergy is phenomenally common. And then we know now that it's essentially genetics and also your environment that's important. You'll see Israel, which doesn't project terribly well, that there is no peanut allergy, and this relates to almost certainly early exposure to peanut in the children's diet. We have a lot of mustard allergy in France, and I'm not sure I understand mustard allergy, but certainly we have a number in our clinic who have mustard allergy, and the majority, 90%, have French genetics of some sort, be it French parents with children either born in France and come here, but there's always a French link. You go to Singapore, there's lots of bird nest soup allergy. You go to Australia, there's more sesame allergy because it's more prevalent. So almost certainly allergy is a combination of what you're exposed to, what's the environment, and a genetic predisposition. But it doesn't matter where you are in the world, milk is the big player in terms of across the globe. So if we look at what's in cow's milk, so this is fresh cow's milk. 80% of the protein is made up by casein, and there are a number of different casein antigens which are recognised. And 20% of the protein is whey. And of the whey antigens, the big one that we really understand is the beta-lactoglobulin. If we look at what's in breast milk, we can see that we automatically have a problem because the casein and whey structure is the wrong way around. And not only that, during lactation, the amount of casein in breast milk varies depending on the stage in terms of how advanced lactation is. But the bottom line here is probably the most important line on this slide, that cow's milk protein, beta-lactoglobulin, is present in human breast milk. And certainly then this probably underestimates. I suspect it's more than 50% of mothers will express it. So lactose intolerance, as I said, is something totally different. As you know, lactose is a sugar, a disaccharide, which is found in milk, and that's the only relationship it has with milk. And the normal state of play is that it's digested by the enzyme lactase in the small intestine, and it doesn't cause a problem. Lactose intolerance exists, and certainly we do see lots and lots of secondary lactose intolerance. This is usually the child that has the gastroenteritis, who then is intolerant of the milk for a period afterwards as the brush border and the enzyme lactase is broken down, so they can't digest the lactose. And the symptoms are essentially due to having lactose in the large intestine, so it's diarrhea, winds, abdominal pain, due to the osmotic effects and fermentation of sugar that shouldn't be in the large intestine. And I see lots and lots of referrals from GPs, where they think they have diagnosed lactose intolerance in a 3-week-old baby, and they've stuck them on SMALF. And they're always wrong, as you know. Primary congenital lactose intolerance is almost incompatible with life. These children do not usually survive. Secondary lactose intolerance is as common as anything, so there's loads and loads around. So primary congenital lactose intolerance is phenomenally rare and usually fatal. So those children that are diagnosed with primary lactose intolerance in the first few months of age almost certainly have cow's milk protein allergy that the GP has misinterpreted symptoms, so it always raises a few eyebrows. But this is lifted from NICE in terms of sort of Ig-mediated symptoms. So certainly we know that symptoms need to be quick, and this is true of any food. Usually in about 20 minutes you will get vomiting, pain, diarrhea. You can get skin symptoms, itch, rashes, urticaria. Runny nose is quite a common feature, particularly in non-IgE milk allergy. We hear lots of stories of snuffly babies, almost certainly have milk allergy, and these children can develop anaphylaxis, as I said. This is again lifted from NICE about how to take an allergy-focused history. This is true of any sort of food. Is the allergen typical for the age of the child? I always ask about the timing of symptoms after exposure. So the child that has a food for the first time at lunchtime, who then wakes up the next morning covered in rash, it almost certainly isn't an allergic mechanism. So we like that nice, clean, causal relationship with food in terms of the time interval. So a little boy has peanut butter for the first time, within 20 minutes he's got runny eyes, he's got rash, he's got swelling. It's much more diagnostic than the child that goes to bed and wakes up with a rash the next morning, and that's usually a viral etiology rather than allergy. I always ask about symptoms. And then previous tolerance. So we do now know that it is theoretically possible to become allergic to a food after being previously tolerant of it. And we now know that it is possible to suddenly become allergic to food. The biggest group that we see this in are usually children with eczema. And our experience is that you get a well-gooding dermatologist that decides to take a big food group out of a child's diet because of eczema. And the reality is that it probably wasn't causing the eczema in the first place, but I can guarantee that if you take foods out for a long period of time, you can make some of these children from intolerant to truly allergic. So we certainly in our practice are very careful that if we are, and we do take lots of foods out of children's diets, don't get me wrong, but we always have a very clear exit strategy, and that is as much as, if there's no improvement in symptoms after 8 weeks, that food needs to go back into the diet. We wouldn't leave a child on a restricted diet if it's no perceived benefit. So you can lose tolerance through avoiding foods. IgE-mediated allergy, I said before that there's lots of nice testing. We do lots of skin prick testing because it's very quick, it's very cheap, which is the most important thing. And you probably may have seen some of this in clinic, but you do a little bit of drawing on the arm, you label up which allergen is which, series of drops from little droppy bottles. You then pierce the skin very gently with a little metal toothpick, and then after 10 or 15 minutes you get a wheel and flare response, and you measure the size of the wheel that you get. And it's painless and it's phenomenally cheap, which is why we like doing it. The size of wheel that you get has no correlation with severity, it just has a correlation with likelihood of being allergic. So these are the numbers, and we have numbers for all sorts of different foods, but for milk, I know if I see a 4-year-old who has a good history of milk allergy, and I do a skin test and I get a wheel of greater than 8 millimeters, I can say with 95% confidence that child is allergic to milk. So we only use testing alongside a clinical history because there's maybe 50 people in the room here. I could test all of you on the way out the door to coffee, and a lot of you will come up positive to peanut or to other foods that are in your diet and you're absolutely okay with. That's because you're not allergic to those foods, you are sensitized. So in order for this type of testing to be meaningful, there needs to be a history of clinical reaction. So if we test all kids with eczema, they've got positive results to everything because they're sensitized, they're not truly allergic. So in order for it to be allergy, you need to have a history to support it. So a positive skin test doesn't necessarily mean you're allergic, and a negative skin test, again, doesn't absolutely exclude allergy, although it's not usually wrong. We do blood tests as well, and again, you've got a number, a grade, which has no correlation with the severity of allergy. All the number correlates to is the likelihood of being clinically allergic. And again, for milk, we get these sort of numbers that, again, 18-month-old with a good history of reacting to milk with rash and urticaria and hives. With the blood test above 5, 95% confident that child is truly allergic to cow's milk. And again, the blood test on its own does not mean you're allergic, it means you're sensitized. You need to have a history of a clinical reaction in order for this to be interpreted as true allergy. So then on to non-IgE mediated milk allergy, and this is the big sort of cohorts of children that we see, in particular with cow's milk allergy. As the symptoms can be delayed and they can be hours to days after exposure. They cause gut symptoms, so it's the frequent vomiting, the regurgitation, the reflux, the diarrhea, occasional constipation, the blood in the stool. In severe cases, you can get iron deficiency anemia. Colic is always an interesting one that no one really knows what colic is. All we know is that Infocol doesn't really work. But certainly colic, I think a lot of these kids who have colic almost certainly have cow's milk protein intolerance. And severe cases we get sort of growth faltering, and it causes skin problems, and it's the eczema. So the typical sort of child that gets referred to as the sort of the 4-month-old, who is fussy feeding, who's always vomiting, who has loose stools, diarrhea, blood, mucus, whose eczema starts about 8 weeks of age, the lion's share of those children will have cow's milk protein intolerance. And again, for taking a non-IG meal history, this is again lifted from mice. Is the allergen typical for the age of the child? And certainly in the first 6 months, milk's the great player because most of these children won't have any other foods in their diet. What are the timing of reaction? And it's not uncommon, for me to hear stories of children, breastfeeding and getting sort of flushing during breastfeeding, or if they're bottle fed, get nasal snuffiness and often redness and itchiness during a bottle feed. What are the symptoms? And then we always take a bit of a milk history. It's not uncommon, as for these children, to milk shop for a while. And by the time they come to our clinic center, they've been tried on numerous different milks. The mother have bought every single different type of feeding cup available in the chemist to try and get their children to feed. So the diagnosis is difficult sometimes, because sometimes I see children, and because the symptoms are so wide and varied in non-IG milk, it's sometimes very, very difficult because there is a big crossover with cow's milk protein intolerance and just common reflux, kids that just reflux, and sometimes it's very, very difficult. But it is important to try and get the diagnosis right, because there's no doubt that getting it right transforms these children's lives. And I think that the biggest area where people often struggle is, does this 3-month-old have milk allergy, or is this just a refluxing child that needs a bit of ranitidine or a bit of sort of Gaviscon or a bit of thickener? COMIS, I'm not sure if most of you are familiar with COMIS, but this is a sort of an awareness tool that was put together to try and really differentiate between reflux and cow's milk protein intolerance. And this is certainly what we use, and if you go to our acute children's assessment unit, this is up on the wall for the junior doctors to look at when they're not entirely sure what is going on. If you download it, it looks a bit like this, and it's a tick box sort of awareness tool, but it looks at sort of scoring across a number of different complaints, of which there's crying, and it breaks down how much does a child cry. There's a bit about the vomiting, and parents are asked to sort of to estimate, how much vomit comes back, which is a bit difficult. The stools are probably the most reproducible because it relates to the Bristol stool chart, which is very easy to follow and not really open to interpretation. And you get a score. So for crying and for vomiting, you score out of 6. For stools, you can get a 4 for constipation. And this represents that some children with cow's milk protein do get constipated, but also you get a big score for diarrhea. So you get both ends of the spectrum. There's then an appreciation of what the skin looks like, and then there's a bit about the respiratory system, which doesn't score as much, but there are certainly some children that will wheeze and get some respiratory symptoms. And essentially you tot it all up, and you get a final score. And essentially if you get a score that's greater than 12, it is likely, with 80% positive predictive value, to be cow's milk protein allergic. If it's less than 12, it is most likely to be reflux. So it's certainly a very, very good tool, and I give this to all the GPs that I give talks to, because sometimes they don't really know. And the number of children that I see at 6 or 7, 8 months of age who are clearly milk allergic, who have been treated for reflux for the first 6 months, who are then land in your clinic age 7 months, and you've got then the difficult job of trying to get these children to take an extensively hydrolyzed formula. Then almost certainly a little bit aversive to feeds, and you get these difficult kids to wean because their early experience of milk has been unpleasant. So certainly getting this right, and sometimes, I'll be honest, I don't know whether it's reflux or whether it is cow's milk protein intolerance, because the two do interplay, and cow's milk protein intolerance will cause reflux. And it's not uncommon for me to clinically treat both conditions, and certainly changing the milk and adding in something for reflux. They always get better, these kids, and then we can stop the anti-reflux medication when they're settled on a new milk. But I usually tend to the difficult kids, the mothers that, at the end of their tether because this child has been screaming all of their life. I tend to treat both fairly aggressively and then worry about the diagnosis perhaps 3 or 4 weeks down the line when it becomes very apparent, because certainly changing the milk usually transforms these children. As I said before, there is no diagnostic test for non-IG mediated milk allergy. This is a clinical diagnosis, and it's based on a symptomatic improvement on removing the antigen, the cow's milk protein. Theoretically, you're then meant to put cow's milk protein back in to the child's diet and look for a deterioration of symptoms. That is not my common practice, and certainly it's a difficult conversation to have with a mother who's now actually got a child that sleeps and feeds properly, to say, well, let's just put you back on that old-fashioned milk and see whether your symptoms come back. It's not something that any mother that I've ever met really wants to sign up to, because by then they're sleeping and the diagnosis is usually fairly straightforward. So in terms of treatment, and I have a very simple sort of way in terms of how I approach children who have got cow's milk protein intolerance. We have the breastfed infant, and we have the formula-fed or mixed infant, so the breastfeeding child that is having a little bit of supplementary milk. The MAP guidance is something that I'm hoping most of you are familiar with in terms of what it's all about, and it looks very busy on this slide. I'm going to break it down. I've got it in a few easier slides. But essentially this was a pathway that was put together predominantly to manage children with suspected cow's milk protein allergy in the first year of life. There is a hot off the press, an updated version about to be released. So this has been around for 3 or 4 years now, and it's already sort of going through its first sort of revamp. I know about some of the changes, so I'll sort of mention them to you as I go along, but this is what the MAP guidance looks like in its sort of its busy form. So it's got a little bit about diagnosis, and then it goes through a little bit about treatment. And it's a very busy slide, but we'll go on to, so this is the bottom line, what you need. So this is how I tend to manage the breastfeeding mother, and it doesn't matter whether this is an IgE-mediated milk allergy or a non-IgE milk allergy, is these mothers need to continue to breastfeed. There is no reason, and I still see numerous mothers who have been told to stop breastfeeding and they put the children onto formulas, which is just the wrong thing to do. These children need to breastfeed. Cow's milk protein, beta-lactoglobulin present in breast milk. So the first thing, of course, we do is that we do elimination diet in the mother. So the mother needs to go dairy-free. And also I tend to make most of the mothers soya-free as well, because sometimes there is a bit of a crossover. These mothers need to be well looked after in terms of their own diet, and need to be on a calcium and a vitamin D supplement. In the new IMAP guidance, there's a bit of variation because there's European use as well, and the Europeans have slightly different calcium and vitamin D requirements than in the UK, but certainly in the UK it's 1,000 milligrams of calcium and 10 mics of vitamin D, and Pregnacare and all of the sort of the companies I usually send them off and buy Pregnacare, and then I tell the mothers to have oats milk, they can have rice milk, in terms of something to put on their cereal and having cups of tea. It's pretty rare to get severe cow's milk protein allergy in a breastfed infant, but we do sometimes see it. This child then needs to be weaned dairy-free, and you'll hear more about that as the day goes on. And certainly after breastfeeding, and or if supplementary feeds are needed during the sort of the first year of life, these children need to be provided with an extensively hydrolyzed formula. So if I see a breastfed mother, I do this exactly, and I ask the GP to prescribe an extensively hydrolyzed formula for the mothers to use as supplementary if they need it, but also to start using in cooking to get the baby slightly used to the taste of it, because certainly weaning any breastfed baby from, as you know, from the breast to any bottle, whether they've got allergy or not, is the devil's work. But I think the earlier they can be exposed to some of these rather unusual tasting extensively hydrolyzed formulas, the better. In the formula-fed infant, all of these children need to go onto an extensively hydrolyzed formula and be weaned dairy-free. There are some children, and we know, and I'll go through the different milks in a second, we have a bit of a problem in the UK with the amount of amino acids that are being prescribed and overprescribed, and we're no different in Leeds, and I think 35 to 38% of children in Leeds are on amino acid-based formula, when we know about 15% of children really need to be on it. There's a lot of overuse, a lot of overprescribing, and GPs often just sticking children onto amino acid-based formula. We've now actually instigated, so amino acid milks are now red listed in Leeds, so a GP can't prescribe an amino acid-based formula unless there's a direct dietitian recommending it or a consultant recommending it, to try and stop this over prescribing of amino acid-based formulas, because most of these children don't need it. There are some, however, who do need it. So certainly if I have to see a child, 4 weeks down the line who is no better, having been on an extensively hydrolyzed, I've aggressively treated reflux to see if that's, and they're no better, then I would then change them on to an amino acid-based formula. If there was a history of anaphylaxis on exposure to milk, and certainly we don't see very many children, it's usually the 6-month-old who's given the Actimel creamy porridge that's laced with skimmed milk powder. We probably get 2 or 3 of those a month, and that's been their first exposure to dairy in the breastfed infant who have bad reactions. We often do put them onto amino acid. And not forgetting that those children with Ig-mediated milk allergy do need a rescue plan, antihistamine and adrenaline injectors if needed. So in terms of the different formulas that are available, I'm sure you all know this, but there are 4 extensively hydrolyzed formulas. There's Nutramigen 1 and 2, there's Actimel Pepti 1 and 2, and you'll all know that essentially an extensively hydrolyzed formula is where the milk companies have taken the milk, they've added a bit of enzyme to it and broken it up into smaller pieces with the intention that those lumps of protein present in the milk the babies do not recognise as being milk protein. So it's just pre-digesting to an extent. And there's a different array, and all of the companies will furnish with their sort of Dalton size. So you can see that some are more hydrolyzed than others. Then there's Althera, and then there's Similac, and they're the sort of the 4 big the 4 extensively hydrolyzed. I know that some parts of the country now they have sort of fairly rigid cow's milk protein guidance, and it may be that there are some of these milks that you are predestined to have to use because the local CCGs have decided that's what's on their pathway. But there's certainly 4 available. As I said, amino acids I tend to give to the anaphylaxis children. There are some children, and I saw one yesterday, a 4-month-old, with severe eczema, and also failing to thrive. And most of those severe children I stick straight onto amino acid-based formula. I don't tend to put them onto an extensively hydrolyzed. If they're that severe, with terrible skin, terrible gut symptoms, then I put on straight to amino acid. And again, the cohorts who don't improve after 4 weeks with an extensively hydrolyzed. Of the amino acid-based formulas, there are 3. There's the Neocate, which has been around probably the longest. There's Nutramigen, it was Nutramigen AA, it's now Pure Amino, and we have Alpha Amino. So these are 100% digested, broken down to the building blocks of milk, so there is no protein at all there, there's no amino acids joined together, it's the individual building blocks. We know that Ig-mediated milk allergy does get better, although we know that there's an unfortunate 20% of children who never attain tolerance, and now sort of testing for allergies as well as try and drill down into these. So we now know that those 20% that never outgrow milk allergy are usually allergic to casein, which is one of the most heat-stable proteins present in milk, so you can do component diagnostics, and we do this routinely now, and particularly the sort of the 10, 12-year-old children who are still avoiding dairy, still report symptoms. If their diagnostic testing shows that they're casein positive, those sort of children that probably won't even tolerate baked milk and certainly won't tolerate milk in their diet. So we use testing now to actually stop them having challenges. Historically, we used to bring these children and do a food challenge. You're 12 years old, let's see if we can get some muffins into you, some baked milk. If the component testing is positive, we don't bother doing that because we know these children will fail. So the advances in testing has actually let us try and decide which children are never going to outgrow milk allergy. We do lots of oral challenges, so we see these Ig-mediated milk allergies because the majority do get better. We do serial skin testing. We look to see how many accidents they've had in terms of accidental exposure. We then bring them into the day unit and we do sort of challenges. we have a very high failure rate, so we accept 50% failure rates, which is really where we need to be, because if we haven't got a failure rate that high, we're not exposing children, a lot of children unnecessarily on restricted diets, so we are proactive to get these children in and sort of see if they can tolerate milk. The non-IG milk allergy, again, we know that the majority of these children do get better. We know that home challenges may safely be performed at home if there's no history of any IG milk. If you look at the MAC guidance, there is a little caveat there, and that relates to, does the child have eczema? And certainly in my hands, I would never ask my dietitians, to support a home introduction of using the milk ladder if the child has eczema and I haven't done any testing, because those are the children that may have lost tolerance, who now may have an IgE-mediated milk allergy, whereas before it was causing gut and skin symptoms. So I'd always test at 10 or 11-month-old before commencing them on a milk ladder. And we have seen some children who have lost tolerance and become more allergic. And the majority do settle. And then we are very clear with the family that we think it's safe to start putting milk in, but I can't guarantee you that the child's eczema will be terrible in a few days. So we tend to do most of our introductions at the start of the week with a dietetic phone call or a nurse specialist phone call about Thursday to see what skin is like and make a decision whether skin has been flared by the milk or not. And if it is, we leave it for a few months, then try again. The milk ladder, again, most of you will be very familiar with this, and in the new IMAC guidance, there's a bit of a revamped version. It's got less steps in it, and it's a bit less sugar friendly. So it's a bit there's less sugar in it, I understand, and there's fewer steps. And it is a bit sort of busy because I'm not entirely sure, lasagna and sort of shepherd's pie, they're fairly similar. And all the kids like to get to level 8 because that's when they can have chocolate. And that's always a big milestone. And most of the time when they get up to level 10, my impression level 10 is quite an important thing because most of the kids on level 10 can probably have school dinners. So we do try and we have a number of kids that get stuck on level 11. Again, I saw another kid yesterday who's 3, who's absolutely fine with a little bit of yogurt, a little bit of cheese, but still has a formula milk because he tolerates that. Because formula milk isn't proper milk, it's still modulated, but he's not quite there yet. And it's just a matter of keeping going, really. And our dietitians are fantastic at just making sure. And the one thing I did with that child because he was old was that this mother's heavily pregnant. The last thing she needs to be doing is making up formula milk for her child. It clearly needs to be an alternative, shop-bought, pre-made milk. So we've changed. There are lots of other milks available. Soy milk and certainly Alpro seem to have taken over the market, and milk is like gin. You can make it from. I'm surprised there isn't a potato milk. There probably is a potato milk somewhere, but soy milk is around, and certainly we use a fair bit of soya. We know that 15% of children who have got IgE-mediated milk allergy will also react to soya, so we're very cautious. And again, we're very cautious. We know that 50% of them will react with skin and gut symptoms, so it's not a milk that we tend to put in the sort of the really severe children. We don't give it certainly less than 6 months. Our dietitians don't really like using it very much less than sort of 10 or 11 months, but we do introduce soy as an ingredient in bread and then sort of soy yogurts, but it's very rare for us to transfer children onto soy milk. Again, the new IMAC guidance, because there is a bit of variation between us and the continent in how they use soy milk, but we use a fair bit of it, and it's certainly the most nutritious out of all of the other milks that you can buy. Rice milk, we never use at all, particularly when you tell the family there's too much arsenic in it. But I do see a number of children, I know that in the continent they do use more rice milk than we do in the UK, but certainly there isn't really much in rice milk of nutritional value, so we don't use a lot of it, although some of the older children do like the taste of it. Oat milk, we use a lot of oat milk, particularly calcium fortified. Hemp milk, we don't really see very much of. There are some parents that do use it, and there's a number of different milks that have come out, sort of the nut-based, there's a hazelnut milk, there's the almond milk. Again, you'll know all about this, but some of these are not terribly nutritious. And certainly I was struck by a presentation I went where somebody actually broke down what's in 100 mils of almond milk. So 100 mils of almond milk has about 97 mils of water, 2 almonds, a pinch of salt, and a bit of calcium carbonate. So you can see there isn't much nutrient. You might as well drink water than drink some of these, sort of nutty milks, which might taste nice on your cereal, but you need to be careful about this calorific content because we want these children to grow. There are lots of sort of different mammalian milks that you can buy, and I certainly see lots because I tend to cover Bradford and Dewsbury. All those children come to me in Leeds, and there's certainly a big cohort who like their sort of goat's milk and their camel milk, and we've got a big Pakistani population that often go back to Pakistan. They have buffalo milk when they're over in Pakistan because you can't get cow's milk. And the other the other interesting thing about male milks is that the similarity between the milks relates to how many toes the animal has. So if you've got an even-toed animal, it's very, very similar to cow's milk. The odd-toed animals are theoretically less allergenic because the protein isn't quite as similar. So rhino milk will be better than buffalo milk. But the bottom line is that we never use any of these milks. So there's no place for unmodified mammalian milks. They're likely to be just as antigenic and they're nutritionally adequate. So we never use them and try and keep people away from them. So in summary, calcium protein allergy is phenomenally common. There are 2 cohorts that we do recognise. There's the Ig-mediated milk allergy, which is the smaller component in terms of population. There's the non-Ig-mediated, which is the big sort of cohort, and certainly the one that you will see daily in your clinical practice. The management is relatively straightforward, and people, if you divide it into the breastfed infant or the mixed infant, so the breastfed infant's mother needs to go dairy-free, make sure the mother's on a calcium and vitamin D supplement, breastfeed as long as possible, and then when that child needs to transition or needs supplement to use an extensively hydrolyzed, only using amino acid for the severe children. All bottle-fed infants should go straight into an extensively hydrolyzed formula, and amino acids should be reserved for those with severe disease or those that have failed to settle on an extensively hydrolyzed. And that is all I have for you.